One example of an inborn error metabolism is congenital hypothyroidism, and I am Ms. Debuco Nicole Uriel to report on this complication. Congenital hypothyroidism is a severe deficiency of thyroid hormone in newborns. It causes impaired neurological function, stunted growth, and physical deformities. The condition may occur because of a problem with the baby's thyroid gland or a lack of iodine in the mother's body during pregnancy. Other name for this complication, congenital myxedema, cretinism, and congenital hypothyroidism in newborns can be caused by a missing, poorly formed, or abnormally small thyroid gland, a genetic defect that affects thyroid hormone production, too little iodine in the mother's diet during pregnancy, radioactive iodine or anti-thyroid treatment for thyroid cancer during pregnancy, use of medicines that disrupt thyroid hormone production, such as anti-thyroid drugs, sulfonamides, or lithium during pregnancy. There are two types of this complication, the permanent congenital hypothyroidism and the transient congenital hypothyroidism. Permanent refers to a persistent deficiency of thyroid hormone that requires lifelong treatment. This permanent congenital hypothyroidism may be due to primary or secondary causes. Primary hyperthyroidism include defects of thyroid gland development, deficiencies in thyroid hormone production, and hypothyroidism resulting from defects of thyroid-stimulating hormone binding or signal transduction. Peripheral hypothyroidism results from defects in thyroid hormone transport metabolism or resistance to thyroid hormone action. Secondary or central hypothyroidism causes include defects of thyrotropin-releasing hormone formation or binding and TSH production. Transient refers to a temporary deficiency of thyroid hormone. It is discovered at birth, but then recovering to normal thyroid hormone production. This hypothyroidism may be caused by maternal or neonatal factors. Maternal factors include antithyroid medications, transplacental thyrotropin receptor blocking antibodies, and exposure to iodine deficiency or excess. The disease process for congenital hypothyroidism. The thyroid gland develops from the bucopharyngeal cavity between 4 and 10 weeks gestation. The thyroid arises from the fourth-branchial pouches and ultimately ends up as a bilobed organ in the neck. By 10 to 11 weeks gestation, the fetal thyroid is capable of producing thyroid hormone. By 18 to 20 weeks gestation, blood levels of thyroxine have reached term levels. The thyroid gland uses tyrosine and iodine to manufacture T4 and triiodothyronine. Inborn errors of thyroid metabolism can result in congenital hypothyroidism in children with anatomically normal thyroid glands. T4 is the primary thyronine produced by the thyroid gland. Only 10 to 40% of circulating T3 is released from the thyroid gland. T3 is the primary mediator of the biologic effects of thyroid hormone and does so by interacting with a specific nuclear receptor. Receptor abnormalities can result in thyroid hormone resistance. The major carrier proteins for circulating thyroid hormones are thyroid binding globulin, thyroid binding prealbumin, and albumin. Infants born with low levels of TBG, as in congenital TBG deficiency, have low total T4 levels but are physiologically normal. Familial congenital TBG deficiency can occur as an X-linked recessive or autosomal recessive condition. The most critical period for the effect of thyroid hormone in brain development is the first few months of life. It is best to thoroughly assess newborns, and the risk assessment for this complication are family health history, physical assessment, and patient's history. Family health history is an important tool to identify individuals and families at increased risk for disease, risk factors for disease, and inheritance patterns of diseases. Because of its importance, all nurses need to be able to elicit family history information and, when feasible, document the collected information in pedigree format. Physical assessment. Assess for initial skin, face, and neck findings. Assess the abdomen for contour, size, symmetry, and umbilical cord location, and palpate to locate viral organs and any masses. Assess for symptoms and signs of congenital hypothyroidism, which includes jaundice, goiter, growth parameters. and a careful examination for features of other congenital problems, especially cardiac problems. Patient's history. A child is at risk for congenital hypothyroidism if he or she has any of these: a chromosomal disorder such as Down syndrome, Williams syndrome or Turner syndrome, an autoimmune disorder such as type 1 diabetes or celiac disease. This is disease involving several hormone deficiencies such as pseudohypoparathyroidism and injury to the thyroid gland. The diagnostic tests for this complication would include ultrasound and scintigraphy. Ultrasound and thyroid scintigraphy helps determine the anatomy and function of the thyroid gland as well as the etiology of congenital hypothyroidism. Radiography. A lateral radiograph of the knee may be obtained to look for the distal femoral epiphysis. This ossification center appears at about 36 weeks gestation. Its absence in a term or post-term infant indicates prenatal effects of hypothyroidism. Newborn screening. Most neonates born with congenital hypothyroidism have normal appearance and no detectable physical signs. Hypothyroidism in the newborn period is almost always overlooked, and delayed diagnosis leads to the most severe outcome of congenital hypothyroidism, mental retardation, emphasizing the importance of newborn screening. The screening laboratory will measure the level of T4 and TSH, thyroxine and thyroid-stimulating hormone. If the heel prick blood T4 level is low and the TSH level is elevated, the results suggest congenital hypothyroidism. These results are sent to the baby's primary care provider. The screening test results must be confirmed by another blood test, one that is taken directly from a vein, not a repeat heel prick. This test will also measure thyroxine and thyroid-stimulating hormone. If the free T4 is low and the TSH is elevated, a diagnosis of congenital hypothyroidism is confirmed. The nursing diagnosis for this complication: fatigue related to impaired metabolic state as evidenced by lethargic. As there is extreme tiredness, fatigue, and just feeling wiped out are common symptoms of an underactive thyroid gland. Risk for ineffective breathing pattern related to decreased energy, because hypothyroidism slows the heart rate and weakens the heart contractions, decreasing its overall function. Related symptoms may include fatigue and shortness of breath with exercise. Lastly, constipation related to hormonal problem as evidenced by altered bowel sounds. Signs and symptoms of congenital hypothyroidism results from the shortage of thyroid hormones, which can cause the body's processes to slow down. The thyroid gland can have a significant impact on the GI system, and babies with congenital hypothyroidism experience constipation. The nursing actions for this complication: monitor vital signs to provide a baseline data and to initiate corrective measures. Monitor client's weight, as this monitors nutritional state and effectiveness of interventions. Promote health teaching and dietary modifications and restrictions to meet client needs. Thoroughly educate parents on the importance of proper medication administration, as well as the necessity to monitor thyroid hormone levels frequently, as thyroid hormone is crucial for brain development. If treatment is not given to babies as directed, it may be necessary to involve social services. Plan adequate rest periods to prevent excessive fatigue. Medical interventions for this complication: we have newborn screening. Screening for congenital hypothyroidism is recommended when a baby is 3 days old. Testing should be performed before discharge or within 7 days of birth. Serum thyroxine concentrations should be maintained. This is to ensure normal growth and development. Serum thyroxine concentrations should be maintained in the upper half of the reference range in the first year, and serum thyroid stimulating hormone measurements should be kept in the reference range. Ultrasonography and scintigraphy. Ultrasound and thyroid scintigraphy help determine the anatomy and function of the thyroid gland as well as the etiology of congenital hypothyroidism. Radiography. A lateral radiograph of the knee may be obtained to look for the distal femoral epiphysis. Follow-up. Laboratory and clinical evaluations must be performed regularly in infants with congenital hypothyroidism during the first 3 years to ensure optimal dosing and of adherence of therapy. Assessment of permanence. If no sign of permanence is found, therapy should be discontinued for 30 days after 3 years of age, and measurements of T4 and TSH should be obtained. Closely monitor the child, and thyroid function tests should be repeated. This is to monitor any suspicion of recurrence and for any abnormal results and findings. For the pharmacological intervention for this complication, levothyroxine. This is the preferred form of thyroid hormone replacement in all patients with hypothyroidism. It has been established as safe, effective, inexpensive, easily administered, and easily monitored. Health teaching for this drug would include parents should crush up each day's tablet and then mix with a small volume of about 1 teaspoon of liquid, either expressed breast milk, water, or formula. This can be given to the baby in a teaspoon or by using a medicine dropper or syringe and squirting the suspension into the baby's mouth against the side or cheek pad. Levothyroxine should not be mixed with a soy protein formula, as soy protein binds thyroid hormone, reducing absorption from the gut. It is extremely important that parents administer thyroid hormone daily to maintain steady blood levels. Thyroid hormones. These agents are administered to supplement thyroid hormone in patients with hypothyroidism. Surgical management would include plastic and reconstructive techniques. Needs, problems, cues, physiological deficit, fatigue. For the objective cues, too little crying, lethargy, fluttering eyelids, frowning, sucking fingers. Subjective cues, the mother verbalized that her baby is sleeping more than usual. Or nursing diagnosis, fatigue related to impaired metabolic state as evidenced by lethargic. For the scientific basis, extreme tiredness, fatigue, and just feeling wiped out are common symptoms of an underactive thyroid gland. Thyroid hormone affects almost every cell in the body. When there isn't enough thyroid hormone, the body's processes start slowing down. In hypothyroidism, the body's fuels are sluggish, and therefore basic body functions like heartbeats and speaking are slow. The objectives of care that should be met. For the general objectives, after 2 weeks of holistic nurse-patient interaction, the client will be able to display absence of fatigue. For the specific objectives, after 8 hours of student-nurse-client interaction, the client will be able to display an improved sense of energy by manifesting less lethargy. Nursing interventions to promote sense of energy. Monitor vital signs, noting pulse rate at rest and when active. This is to establish a baseline of non-exertion energy expenditure and to compare them with resting values. Meet the nutritional needs of infants. For a fragile infant or child, feeding is similar to exercise in an adult. Discuss with parents reasons for fatigue and emotional lability. This is to promote the family's understanding on the benefits of treatment and interventions. Discuss with the importance of good sleep and discourage daytime naps. Restorative sleep is essential. Children should get 8 to 10 hours of nighttime sleep. Alternate activity with periods of rest and uninterrupted sleep. This is to prevent excessive fatigue. Provide a quiet environment, cool room, decrease sensory stimuli, soothing colors, and quiet music. This reduces stimuli that may aggravate agitation. Encourage parents to restrict child's activity and rest in bed as much as possible. This may decrease negative energy, promoting relaxation. Provide comfort measures like judicious touch and massage. This is to calm their senses and to promote sensory soothing. Aid the parent to develop habits to promote effective rest or sleep patterns. Promoting relaxation before sleep and providing for several hours of uninterrupted sleep can contribute to energy restoration.
Collaborate with a dietitian to help attain nutritional needs.
After 2 weeks of student-nurse-client interaction, the client was able to display absence of fatigue and improved sense of energy.
Good day, I am Mr. Co Ronald, and I'm going to report about phenylketonuria. Phenylketonuria, also called PKU, is a rare genetic disease inherited as an autosomal recessive trait. It causes an amino acid called phenylalanine to build up in the body. Without the enzyme necessary to process phenylalanine, a dangerous buildup can develop when a person with PKU eats foods that contain protein or eats aspartame, an artificial sweetener. This can eventually lead to serious health problems. For etiology and cause, absence of the enzyme phenylalanine hydroxylase, which is necessary to convert phenylalanine as an essential amino acid into tyrosine. PKU is caused by a defect in the gene that helps create the enzyme needed to break down phenylalanine. Without the enzyme necessary to process phenylalanine, a dangerous buildup can develop when a person with PKU eats foods that contain protein or eats aspartame, an artificial sweetener. Most forms of PKU are caused by mutations in the PH gene on chromosome. Untreated PKU is associated with an abnormal phenotype which includes growth failure, poor skin pigmentation, microcephaly, seizures, global developmental delay, and severe intellectual impairment. For types of PKU, hyperphenylaninemia, the lowest level above normal. Mild PKU, blood levels are mildly elevated. For moderate or variant, levels are not low but not high. And for classic PKU, blood levels of phenylalanine are high. Here we have the disease process shown on the diagram. For risk assessment, classical PKU is an autosomal recessive disorder caused by mutations in both alleles of the gene for phenylalanine hydroxylase found on chromosome 12. In the body, phenylalanine hydroxylase converts the amino acid phenylalanine to tyrosine, another amino acid. For signs and symptoms, a typical musty or mousy urine odor that is so strong that it often pervades not only the urine but the entire child. Blue-eyed with very fair skin and light blonde hair child. And also growth failure, frequent vomiting, irritability, hyperactivity, and unpredictable and erratic behavior, and also skin is prone to eczema. Older children commonly displays bizarre or schizoid behaviors patterns such as fright reactions, screaming episodes, head banging, arm biting, disorientation, failure to respond to strong stimuli, and spasticity or catatonia-like positions. For diagnostic tests, Guthrie inhibition assay test, it is a diagnostic tool to test infants for phenylketonuria a few days after birth. To administer the Guthrie test, doctors use Guthrie cards to collect capillary blood from an infant's heel, and the cards are saved for later testing. And also urine tests. Results of urine tests may be negative in the first month of life and are rarely used in current practice. Nursing diagnosis. First, delayed growth and development related to cognitive impairment secondary to PKU. Phenylalanine is an essential acid for normal growth and development. Second, disorganized infant behavior related to congenital or genetic disorder. Child behavior may be altered or impaired, leading to abnormal social, cognitive, and motor skills that are inappropriate or underdeveloped for his or her age. And the third is risk for injury related to extreme hyperactivity and gait disturbance. Congenital abnormalities or untreated PKU may interfere with normal behavior and gross motor skills, leading to the child being increasingly prone to injury. For nursing management, teach the family regarding the dietary restrictions. Inform family caregivers of the foods that they should avoid giving the infant once he is allowed to take solid foods. Special formulas are also indicated instead of regular formulas or breast milk, such as lofenalac and phenyl-free formulas. Offer support to the family emotionally. especially after the diagnosis, so they could cope with the shock, anxiety, and stress. Educate the family on the disease process and how they could help the child grow as normally as he could. If a child's phenylalanine control is kept within the acceptable range, growth and development will not be affected. Educate the family caregivers on how to handle the child, with safety being the priority in case of convulsions, so that the family will have knowledge on how to handle the child with safety and how to handle it properly. And also monitor vital signs to detect any abnormalities and monitor medical problems. For medical management, Guthrie bacterial inhibition assay test. This screening uses blood from a simple heel prick. The test is most reliable after the newborn has ingested some form of protein. The accepted practice is to perform the test on the second or third day of life. Bacillus subtilis present in the culture medium grows if the blood contains an excessive amount of phenylalanine. And for newborn screening test, this screening test is most reliable if the blood sample is taken after the infant has ingested a source of protein. For plasma phenylalanine, a qualified laboratory should measure plasma phenylalanine and tyrosine. Screening for PKU includes determination of phenylalanine levels, the standard amino acid analysis done by means of ion exchange, chromatography, or tandem mass spectrometry. Phenylalanine-free formulas. A formula low in phenylalanine should be started as soon as the condition is detected. Lophenolac and phenyl-free are low phenylalanine formulas. Best results are obtained if the special formula is started before the newborn is 3 weeks of age. Restricted diet. A low phenylalanine diet is a very restricted one. Foods to be omitted are breads, meat, fish, dairy products, nuts, legumes. The child remains on the diet at least into early adulthood, and it may even be recommended indefinitely. Amino acid supplementation. Other essential amino acids are supplemented using various medical foods, and vitamin, mineral, and other micronutrients are followed closely. Stringent phenylalanine restricted diets have been reported to cause deficiencies of iron, zinc, selenium, and other nutrients and essential amino acids in patients with PKU. And avoidance of aspartame. Aspartame must also be avoided. Phenylalanine is one of the primary components of aspartame. It is found in many artificially sweetened foods and soft drinks, as well as some vitamins and medicines. For pharmacological management, sapropterin. Some patients with PKU experience significant lowering of plasma phenylalanine levels after administration of sapropterin, a commercially available FDA-approved form of the tetrahydrobiopterin cofactor. And also enzyme therapy. An alternative enzyme therapy for PKU in clinical trials involves the use of an injectable form of phenylalanine ammonium lyase, an enzyme capable of substituting for phenylalanine hydroxylase. This therapy is currently under investigation for the potential treatment of patients with PKU who do not respond to BH4. And I'm also going to report about galactosemia. Galactosemia is a disorder of carbohydrate metabolism that is characterized by abnormal amounts of galactose in the blood and in the urine. It occurs in about 1 in every 60,000 births, most often as an inborn error of metabolism, which is transmitted as an autosomal recessive trait. People with galactosemia are unable to fully break down the simple sugar galactose. Galactose makes up 1/2 of lactose, the sugar found in milk. If an infant with galactosemia is given milk, substances made from galactose build up in the infant system. These substances damage the liver, brain, kidneys, and eyes. For etiology and cause, galactosemia is a rare autosomal recessive disorder that results from various gene mutations leading to 3 distinct enzymatic deficiencies. The most common type of galactosemia is the classic galactosemia. Results from a deficiency of hepatic enzyme galactose 1 phosphate uridyl transferase and affects approximately 1 of 47,000 births. The other two varieties of galactosemia involve deficiencies in the enzyme galactokinase and galactose 4 epimerase. These are extremely rare disorders, are all involved in the conversions of galactose into glucose. Galactosemia occurs due to disruptions or changes in the GALT gene, resulting in deficiencies of the GALT enzyme. This leads to abnormal accumulation of galactose-related chemicals in various organs of the body, causes the signs and symptoms and physical findings of galactosemia. Galactosemia is inherited as an autosomal recessive genetic condition. For types of galactosemia, classic and clinical variant galactosemia or the type 1 galactosemia. Classic and clinical variant galactosemia are rare genetic metabolic disorders. The patient with classic galactosemia carries deleterious mutations in both copies of their GALT gene so that their blood shows essentially no detectable residual GALT activity. The patient with clinical variant galactosemia also carries deleterious mutations in both copies of GALT gene, but one or both mutations leave a small amount of residual GALT activity. In the vast majority of cases, the GALT mutations in classic and clinical variant galactosemia are inherited so that both parents of an affected child are carriers. And for Duarte variant galactosemia, it is much more common than classic or clinical variant galactosemia. In many populations and also results from mutations in the GALT gene. However, instead of carrying severe mutations in both copies of their GALT gene, patients with Duarte variant galactosemia carry one GALT copy with a severe mutation and a second GALT copy that is only very mildly impaired and that shows a collection of characteristic sequence changes that classify it as Duarte, also called D or D2. A child with Duarte variant galactosemia therefore generally has one parent who is carrier for a severe GALT mutation and one parent who is carrier for the Duarte variant. And for galactokinase deficiency or the type 2 galactosemia. Galactokinase deficiency results from inheritance of deleterious mutations in the human GALK1 gene, leading to loss of galactokinase enzyme activity. Like patients with loss of GALT activity, patients missing GALT activity cannot fully metabolize galactose so that if they consume a diet high in lactose or galactose, they will accumulate high levels of galactose and galactose metabolites, including galactitol and presumably galactonate. Though this metabolite is rarely measured, unlike patients who are missing GALT activity, patients with galactokinase deficiency do not accumulate high levels of GAL1P because GALK is the enzyme that is synthesized GAL1. And for epimerase deficiency or the type 3 galactosemia, epimerase deficiency results from inheritance of deleterious mutation in the human GAL gene, leading to partial loss of UDP galactose 4 epimerase enzyme activity. Like patients with loss of GALT or GAL activity, patients with impaired GAL activity cannot fully metabolize galactose. However, unlike patients with classic galactosemia or galactokinase deficiency, all patients with epimerase deficiency reported to date exhibit only partial loss of enzyme activity. Here we have the disease process shown on the diagram. For risk assessment, galactosemia is inherited in an autosomal recessive pattern. As an autosomal recessive disorder, the parents of a child with galactosemia are unaffected. Healthy carriers of the condition and have one normal gene and one abnormal gene. For signs and symptoms, symptoms appear as soon as the child begins formula or breastfeeding. Abnormal amounts of galactose in the blood, jaundice often present and persistent that resulted from cirrhosis that is caused by hepatic dysfunction, usually present in the second week of life. Hepatomegaly becomes present as cirrhosis develops. Splenomegaly as a result of portal hypertension. Bilateral cataracts, usually recognizable by 1 or 2 months of age. Cerebral damage manifested by lethargy or hypotonia. Kidney damage manifested by galactosuria. And vomiting, diarrhea, and weight loss, progressive symptoms that begin to show on the ingestion of milk. And characteristics of malnutrition and dehydration. And Escherichia coli sepsis. For diagnostic tests, newborn screening. A positive indication on the newborn screen must be followed by a quantitative erythrocyte galactose 1-phosphate uridyltransferase analysis by a laboratory that routinely performs biochemical genetic testing and consultation. Butler test. A screening test called Butler test can be used to test for the disorder. And the last one is GALT isoelectric focusing electrophoresis test. A GALT isoelectric focusing electrophoresis test helps distinguish variant forms such as the Duarte defect. Nursing diagnosis. First, an effective breastfeeding related to intolerance of galactose. Breast milk contains galactose. Breastfeeding will provide less energy and delay or restrict growth as galactose is a form of sugar. And for the second one is altered nutrition less than body requirement related to restrictive diet. Nutrition is restricted as breastfeeding and formula milk contain galactose, and infants cannot tolerate or break down galactose. And the third one is diarrhea related to ingestion of galactose containing substance. Patients with galactosemia cannot break down galactose. Therefore, there would be buildup of galactose in the body leading to diarrhea to evacuate it. For nursing management, milk substitution. A soy-based formula, meat-based formula, or Nutramigen or other soy-based formula that contains no galactose should be substituted into the infant's diet. And also teach the family regarding the dietary restrictions. Infants with galactosemia must remain on a restricted diet and maintain low blood galactose levels throughout life. Read food labels carefully. Labels on all processed foods must be read carefully for ingredients which are milk products. Educate the client. Ascertain the level of understanding of the family, caregivers, and provide complete information on the disorder. Give food list to the family to ensure appropriate foods are chosen. Instruct parents to ask their local pharmacist about galactose content of any over-the-counter or prescription medication to avoid any galactose containing medications. Medical management. Screening tests. To analyze cord blood if a child is known to be at risk for the disorder and can be used to identify enzyme defects. Transfusions. Clotting abnormalities may be cryptic and require fresh frozen plasma treatments. Prescribe a galactose-restricted diet for infants. Prescribe a galactose-restricted diet for infants who are galactosemic. A substitution for milk such as Nutramigen and progestin can provide galactose-free nutrient for the infants. Enhance residual transferase activity, replace depleted metabolites, or use gene replacement therapy to improve the prognosis for these children who have galactosemia. A newborn screening is done through galactosemia test, which is a blood test or urine test, to check for the 3 enzymes that are needed to change galactose sugar into glucose, and calcium supplements to help ensure they receive enough calcium. For pharmacological management, calcium supplements to help ensure they receive enough calcium, and vitamin D and vitamin K supplements to help prevent decreased bone mineralization.